Now, do you think because colorectal cancer doesn't run in your family that you shouldn't bother with getting a colonoscopy? Well, think again. Dr. Scot Ackerman is one of the First Co's leading oncologists, and he joins us every week, every Friday, to talk about the important issues. And today he brings us up to speed on this prevalent cancer. Dr. Ackerman, always good to see you.
Thank you, Nick. Good to see you.
Give us a little background. Catch us up to date on colorectal cancer.
Well, colorectal cancer is cancer of the colon and the rectum. We group it as one group of diseases. Is the third most common cancer in men and women. Typically, cancer of the colon or cancer of the rectum, again, they progress fairly similarly. They usually begin as a polyp in the lining of the large intestine or the rectum. And most of these polyps are benign, little polyps, and they don't cause too many problems. But these polyps have the potential to grow and de-differentiate and become cancerous lesions.
Is this something that we should worry about if we don't have a family history of this type of cancer?
When we talk about colorectal cancer, we talk a lot about family history. But the truth is that colorectal cancer can affect anyone. There's about 130,000 cases of colorectal cancer diagnosed annually in the United States. And of those, 80% of those people with colorectal cancer have no family history. But 80% have no family history, 20% do. But we need to be aware of risk factors, because there are risk factors, including family history. There's certain genetic mutations that are associated with a higher incidence of colorectal cancer, something called Lynch syndrome, someone who has a personal history of polyps or inflammatory bowel disease. So that's not a genetic or family history thing, but if they have a personal history of polyps or if they have inflammatory bowel disease, they're at higher risk for colorectal cancer. And people of African American descent or Jewish descent are also at higher risk of colorectal cancer.
So if 80% is at risk that doesn't have a family history, what can we do at that 80% to prevent this from happening?
Right, so 80% of colorectal cancer patients have no family history, but they're at risk for whatever other reasons. And there's certain things that we could do to minimize our chance of getting colorectal cancer. One thing we found that there's an association with red meat and processed meats, processed salami and hot dogs and those sort of meats put one at higher risk of colorectal cancer. People who are obese tend to have a higher incidence of colorectal cancer, so we recommend people stay physically active, maintain an appropriate body mass index. We've talked about the BMI before,
right.
So body mass index. And you could do a little calculation, there's apps for that, where you want to have your body mass index below 25. Tobacco use has been associated not just with lung cancer, but also bladder cancer, pancreatic cancer, and colorectal cancer. Also, excessive alcohol intake is associated with increased risk of rectal cancer and colon cancer. So we generally recommend no more than 1 drink a day for women and 2 drinks a day for men. It seems to be a little higher threshold for men. And screenings for colorectal cancer not only diagnoses colorectal cancer, but also can prevent colorectal cancer. If you have a colonoscopy and a polyp is found and the endoscopist removes that polyp through the colonoscope, he or she is not only removing a polyp, but also preventing polyp from becoming cancerous. So we've seen the incidence of colorectal cancer drop with the increased use of colonoscopy.
Is there a certain time frame when we should start, a certain age that we should start getting screenings? And is it different if we have a family history or if we don't?
Yes, absolutely. So the recommendation is that all Americans over the age of 50 have colorectal cancer screening. And colorectal cancer screening there's different ways to do it. There's sigmoidoscopy, there's fecal occult blood testing, there's colonoscopy. I'm an advocate of colonoscopy. That's a test where the entire colon is evaluated. It doesn't need to be done as often as the other tests to provide appropriate screening. So my recommendation is that at age 50, get a baseline screening colonoscopy.
Okay.
If you're at high risk, you may want to start younger, and high-risk patients, meaning those with a family history of family history, if they're African American or if they're Jewish, to start have the first colonoscopy at age 40. So move it up 10 years. If your colonoscopy is negative and there's nothing found, you don't need to have one but once every 10 years. But if the endoscopist finds a polyp or something like that, he or she may want to recommend colonoscopy more often, like every 3 to 5 years. But generally, if you have a clean colonoscopy, you're good for for 10 years.
Any new advancements in how we get checked or how you take care of these things?
Well, the colonoscopies are much easier than they were before. It's always the prep we talk about. The prep for the colonoscopy seems to be worse than the colonoscopy itself.
And the anticipation of.
Right, absolutely. But the prep is much more easy than it had been in the past. You drink some water, you take a pill, drink a lot of water actually to kind of flush yourself out. But there's some new tests coming along. There's called a virtual colonoscopy with a CAT scanner. The CAT scan is a very high resolution CAT scan. Is almost as good as a regular colonoscopy. There's a sigmoidoscopy you could do. There's a new camera, a new camera pill.
Camera pill?
Yeah.
You just swallow the pill?
Yeah, it's a camera that's in a pill, and you wear a little fanny pack, and it transmits video images to the recorder in the fanny pack.
And then you just turn in the fanny pack.
And you turn in the fanny pack after a day or so,
wow.
and the physicians can analyze that. But the problem with that is that the pill kind of tumbles and rolls as it goes through the colon, and there's potential for it to go around a tumor and miss it. I still think these are all kind of cool things to do, but I think the easiest and best and efficient, the tried and true method is colonoscopy.
Dr. Ackerman, as always, good
you,
to see you, good information, and thank you for sponsoring this segment. If you have any questions regarding today's topic or any other health questions, you can connect with Dr. Ackerman on Facebook by visiting him at facebook.com, First Coast Oncology.